All right, y'all. Hello, everybody, online and in person. Hi, we appreciate y'all for being here today. So we are going to go ahead and get started here. I need to grab a piece of paper. Sorry. Oh, there's no order for epinephrine. Okay.
Right name, in the real world.
Okay. So we're going to go ahead and get started. Thanks for joining us today for our session today about routinizing patient-centered HIV care. Yeah. That's okay. All right, so just a couple quick housekeeping notes, and then I'm just going to pass it right along. So this activity is going to be recorded. I think it's already recording. Perfect. It is. I just had to make sure. All right, quick disclosure to our learners. So no individual with the ability to control the content of this activity has any relevant financial relationship with ineligible companies to disclose. This activity received no commercial support, and UTA's ConHigh is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. Our learning outcome for today, participants will report an increased knowledge of the HIV disease process, screenings, medications, and care of patients with HIV, as evidenced by 90% of participants describing at least one expected change or enhancement in their professional practice based on information learned during this activity today. Our contact hours for today, you are going to receive 1.5 contact hours. If you would like, for the people here in person, you'll need to sign that little sheet over there if you did not already to receive contact hours. If you guys will please allow up to 2 weeks for these to be emailed to you. And then the evaluation code will be at the end. So you guys will just complete the evaluation code in order to get those contact hours. Okay. So I think this goes into yours. Is this yours? All right. So I'm going to introduce Brian Tyler Orr. I'm going to read a little bit about him, and then I'm going to pass it right along. So I won't take up too much time. So Brian Tyler is a public health practitioner with over 5 years of experience in reducing barriers to care for those living with HIV. Since being diagnosed with HIV at 20, Brian has shaped his career to be in positions to create equitable systems of care for communities disproportionately impacted by the HIV endemic in the U.S. South. Brian Tyler pursued his MPH to prepare himself for leadership roles that promote quality programs that integrate systemic approaches to meet the unique and holistic needs of people living with HIV. He shared his insight and evidence-based practices at STD Engage and the Biomedical HIV Prevention Summit in 2023. His contributions across the HIV continuum of care led Brian to be recognized by the U.S. Department of Health and Human Sciences for expanding technical assistance and creating collaborative networks across intersectional partners with the intent to end the HIV epidemic. He is from Tarrant County Public Health, and I'm really happy to introduce him. So I will let him take it from here and tell us all about HIV. Thanks, y'all.
Good morning. Good morning. It is morning, right? Okay. Yeah. So thank you for the lovely introduction. Again, my name is Brian Tyler. I go by he, him pronouns. I'm an epidemiology specialist here at Tarrant Public Health under the specialized division of ending the HIV epidemic. Of course, this program today is called Routinizing Patient-Centered HIV Care with these 3 learning objectives here described above. I will not go over all of these, but essentially I just want to increase everybody's capacity to be able to routinize HIV screening, treatment, prevention, and care for those impacted by the HIV epidemic. I want y'all to feel confident having these conversations with their clients because they're very, very important in terms of assuring people of knowing their status and accessing adequate treatment and prevention services across the continuum.
Just going to switch screens really quickly because it was sharing the wrong screen.
Oh, no worries.
Sharing the right one now. Yeah, it's good. It's good. Okay.
And we back and we live. Okay. Before we begin, for people that are in the in person, also virtually, please pull out your cell phones real quick to scan this QR code. We are going to get super duper uber interactive today because I do not want to make this into a lecture, but more of an immersive experience for all learners, both in person and virtually. So I'll give y'all some time to tap into that. And then I'm going to reverb. We're going to do Control Alt. Oh, yeah, Alt tabs.
Let's start playing.
That's a lot.
You know, that's a lot of us. I mean, it's like,
Oh, so I'm pulling up the wrong thing. So, y'all still, y'all can see this screen. Stop sharing real quick.
There we go.
Stop sharing my screen for a moment or that people can see on my end. Okay.
I was okay. So, and push out.
Okay, I see you.
It's shown on screen.
Oh, it is? Okay, perfect. So, for people who are in person, I would like for y'all to tap into this QR code. The first question should be showing up on your screen. I just want to get more of a feeling of who's in the room with us. I wanted to first ask y'all to share exactly like what are you feeling? How are you feeling at this very moment right now before we get started? I was going to try and check the temperature in the room, make sure everybody is ready for this experience today. Just take a few moments to type in one word that describes exactly how you're feeling at this very moment. And then those answers should be popping up on there as soon as y'all submit them. Submit it. Yeah, that's just focus. There you go. Boom. Okay. So I see excited.
Caffeinated, I love that.
Okay. I see caffeinated. I need to grab some coffee too, probably. But good, interested, ready, productive. Hang in there. Aren't we all? Because life be life. All right. So we'll go on to the next question, which is should be. Um,
Oh, there we go.
oh no, that's not the right one.
Oh, I'm like,
I got a poll.
Me too.
yeah, yeah.
Yeah, there's, yeah.
Mm-hmm.
That's what I got.
So now we'll get there. So the next question that I have for people in person, also in virtual setting, is how comfortable are you with discussing HIV and or sexual health with your friends, family, or clients? There's an option for very uncomfortable, which it can be very uncomfortable, even for me sometimes. Uncomfortable, neutral, comfortable, or very comfortable. There's different people here from different subject matter expertise that may be able to feel more comfortable in the sphere. Just wanted to gather some more insights with that.
Share.
Yeah, go ahead. And it's just share in real time. Yeah, it's sharing in real time right now. So from what I'm seeing, there's a lot of neutral in there. People are very comfortable for the most part. I only see a few people that are uncomfortable. Okay, okay, so we are comfortable. Cool, cool, cool. So at this point, we're just going to be expanding people's knowledge base here. So I think that's pretty cool. And then let's see, I think
Look at round goes to.
I got you. No, no, you're good. That's the power. But that's fine. Let's see. Let's get that. This was going to show results in the power. That's okay. The next question is, how would you describe the area you serve or plan to serve in the future? I'm going to make that loud. Is it showing up on your screen? Right? Is that next question? You know what? That's okay. We're going to skip the polls, okay? So we're going to skip this. we're going to continue to move on to the content, which is okay. We're going to implement this.
Yeah.
All right. So for everybody in the room, this should be very, very not new information, but for those who don't have a good understanding of HIV, I'm going to go through this very, very briefly. So next slide. So HIV, which is short for human immunodeficiency virus, is a virus that attacks the immune cells that are called CD4 plus cells. Okay, and basically what this does is that once it destroys our CD4 count, it does bring down our immune response significantly to everyday opportunistic infections. Currently, there are no cure for HIV, but there is plenty of treatment options for people living with HIV that allows people to live long, quality, and sustainable lives. And the quick origins based on science and theory, it is theorized that the origins of HIV is due to, as can be traced back, to the simian immunodeficiency virus that is found in chimpanzees. It was first originated in the Dominican Republic of Congo, which is in Africa. Okay, and that's traced back to 1960s. Okay, and we see the HIV-1 type that is typically seen in the United States that has been traced back to DRC. Okay, and there's also an HIV-2 subtype as well, but you kind of see that in other more so, I don't want to say underdeveloped, but other countries like Africa and across the states per se, and other areas not in the U.S. But HIV-1 is typically the one that we see domestically here in the states. Next slide, please. So the first cases of HIV that actually showed up in the U.S. started in 1980. We saw 5 queer men that had really opportunistic infections that showed high volumes of PCP or pneumonia. A lot of these people were found to have HIV later on. It was defined as HIV later, but at the time it was just known as GRID, which is gay-related immunodeficiency. A lot of queer men suffered severely from pneumonia, and then it was traced to have spread from Los Angeles to places like New York, San Francisco. As you can see on this little epi tracks right here, it shows the index case right here. And then it ended up going to LA, New York, and all the surrounding areas on bicoastally in the United States. And then it was learned to find out after many scientific innovations that this wasn't just related to queer men, but also this could impact people from all spectrums of life. So the HIV life cycle, I'm only going over this briefly because you can have 10 slides in this and you go into detail. But the only reason why I'm bringing this up is because a lot of our biomedical interventions that either prevent or treat HIV disrupt this life cycle. There's 3 enzymes that really do contribute to HIV and how it manifests in the host cell. It's reverse transcriptase, integrase, and protease. A lot of these enzymes do aid in a lot of these and aid in a lot of this life cycle here. So, for example, you see here that HIV is basically inputting single-stranded RNA into the host cell, and then what reverse transcriptase does is that it takes that single-stranded RNA, makes it into double-stranded DNA, and then it's integrated into the host cell where replication begins, and then it buds off into other cells and affects other CD4 cells. Okay. That's basically all of it in a lump sum, because trust me, that can go really, really deep. And this is not necessarily a biology, cellular, molecular training, but this is just a brief overview of the life cycle so we can understand how biomedical interventions do intervene in either preventing or treating HIV. So modes of transmission for HIV are broken into 4 different categories, really only 3 because blood transfusions, this rarely happens nowadays, but I wanted to bring it up just in case. So 3 main modes of transmission are sexual contact, either anal or vaginal. Oral is in the science, but it's very, very low risk behaviors in terms of transmitting HIV from one person to another, unless you have maybe gingivitis or really open sores in there. You rarely see oral transmission occur, but sexual contact is a mode of transmission. Needle sharing. When you are injecting drugs and there's no clean needle share, that is also a direct transmission of HIV that way, which is one of the higher ways of transmitting HIV, especially amongst people who are not suppressed. and perinatally, which means basically from mother or parent to child, before, during, or after delivery and pregnancy. Some factors that actually contribute to or decrease the risk of motor transmission, viral load. So if someone has a high viral load or is not taking HIV medicine, they're more likely to transmit HIV that way. If someone has an existing STI like syphilis, chlamydia, gonorrhea, that predisposes people to HIV as well. Because if you're predisposed to one STI, you're going to be predisposed to others. Tearing, abrasions, and bleeding, whether it be through menstrual cycles or through anal sex, where there's a lot of tearing if you're not utilizing lubrication, that can be a portal of entry as well for HIV. Factors that do decrease HIV transmission, lower viral load, which we'll talk about that a little bit later. When someone is living with HIV, is at an undetectable viral load, they cannot transmit HIV through sex, but we'll talk about all these other transmissions as well. PrEP and MPEP, which is something we'll talk about as well. Condoms, lubrication, and circumcision. It is research and theorized that circumcision does reduce HIV transmission up to 50% when someone is circumcised. But, give or take, HIV transmission still occurs among people who are circumcised. I only bring this up because I want to talk about the modes of transmission and the risk associated with them. Again, blood transfusions don't occur much, but that is the highest risk per exposure. Anybody that has a blood transfusion with someone who is living with HIV is probably going to get HIV. But that's why we test for blood every single time we do a blood transfusion so we can prevent that from happening. That is a standard of care across the United States. Needle sharing would be the second highest mode of transmission in this category here. And then percutaneous needle stick, which is just like not even tearing the skin, was a little bit lower. But when we go into sexual transmission, which is the most common transmission mode for most cases of HIV, we're going to talk about how anal receptive intercourse is typically the highest mode of transmission, especially if you're the receptive partner. If you're not using lube, if someone's kind of big, that can cause tearing, okay, in that rectum area if you're not doing it with care. If you're the assertive anal partner, that drops significantly to 11 per 10,000 exposures. Receptive penile vaginal intercourse kind of goes down from there. And then here, like I said before, receptive oral intercourse, very low, like nearly non-existent. However, things do facilitate that, like open storage and dividers, things of that nature. So we do want to talk about oral care a lot of times when we talk about HIV transmission. And again, the things that don't transmit HIV, biting, spitting, sharing food, hugging. I just hugged everybody here. I'm a person living with HIV. You cannot get that from casual contact. Okay. So next slide, please. So HIV disease progression. So when someone acquires HIV, typically this is how the disease progression kind of begins. We're going to start with acquisition, right? So in the acute phase, typically viremia or viral load shoots up high, like 10,000, millions, like a bunch of copies in the body. It goes up significantly. During this acute phase, most people who are living with HIV or acquire HIV will go through like a flu-like symptoms. They may acquire like HIV, like a rash that's associated with HIV that's in your torso or your deltoid areas. So you experience those symptoms. They're short term. They go away after a while. People who typically seek help for these symptoms usually treat the symptoms directly. So they'll take a Tamiflu. They'll take like ibuprofen, whatever the case may be. It may take a little bit while than most people to overcome that, but typically the symptoms go away. And you go into the latency phase. The latency phase is when your viral load is still high, but you kind of see it dip a little bit. You see it dip a little bit, but then after a while, it kind of goes back up. With your CD4 count's always going to go down, no matter how long you have HIV, no matter what stage you're in, if you don't have treatment. But after a while, that viral load continues to go back up until you reach a CD4 count of 200 copies per cubic millimeter of serum. When you reach 200 copies of CD4 count, that's when you reach the H stage. But your viral load continues to go up until you receive treatment or until you're not with us anymore. But that's pretty much the disease progression of HIV in a lump sum. So signs and symptoms in these three different stages, you have your primary, you have your latent, and you have your AIDS status. Again, typically when you acquire HIV, you kind of exhibit these symptoms within 1 to 4 weeks. Again, very much so like flu-like symptoms from headache, fatigue, just malaise, so many different things that you can experience. Night sweats, vomiting, nausea, you name it. Typically, people experience these flu-like symptoms at first. Viral replication is high, CD4 count continues to decrease, but these flu-like symptoms do pass over time, and people feel fine. A lot of times, people may see a provider for this, but they may not get tested for HIV, so they don't know their status in the acute stage. Then we go to the latent stage. Viral replication slows down, as we saw before, kind of dip down a little bit, dip down a little bit, dip down a little bit, but the CD4 count continues to decrease as well. In this stage, you do see an asymptomatic stage where people don't experience really any symptoms. And people do not think that they are sick. They don't feel sick. They don't look sick. So they don't really go and seek out testing because they feel like they're fine. Unfortunately, there's a stigma that if you have HIV, you look a certain way, which can be true, but for most people, it's not. They're everyday people that are walking amongst us today. Some symptoms that you may experience here within this latency stage that may seem like everyday things is diarrhea, night sweats. You may have very subtle but swollen lymph nodes in this stage too. You also probably experience that in the primary stage as well. But a lot of people just kind of chalk this up to just, getting older, whatever the case may be. And again, they don't get tested in this stage. However, in the AIDS status, again, we talk about how the CD4 count drops down to 200. Then you start seeing clinical presentations of opportunistic infections, which we'll talk about in the next slide. But without treatment, people typically only survive 3 years after they reach the AIDS status. And sometimes, depending on somebody's immune response, you can reach AIDS status or reach this 200 below 200 cell marker relatively quickly. So it's just all variable. No, you're good. You're good. Some opportunistic infections that you may see in a clinical setting for people who are living with HIV but are not receiving treatment. Herpes simplex 1, oral herpes is very common. Oral thrush, you see this here. A lot of people who progress significantly to the AIDS status may also experience a lot of PCP, invasive pneumococcal infection, PCP within the hospital settings, if not tested or not treated, okay? And these are life-threatening. Like these, well, a lot of people have herpes. However, a lot of these opportunistic infections, even the common cold, could put someone living with HIV with a low CD4 count in the hospital, and they could pass away. So, next slide. When we talk about the U.S. HIV epidemic today, what this slide basically, what I want to personify on this slide is that over 50% of new HIV cases show up in the South. Over 50%. There are some variability in that, but the South just gets hit disproportionately by HIV in comparison to some of the other regions in the US. And we can theorize that. I could have made that into a poll everywhere, but I don't think we're working today, so we're just but there's a lot of reasons why the South is disproportionately impacted by HIV. One of the things that I think of is just access. We think of lack of Medicaid expansion. We are in the Bible Belt, so there is a lot of stigma. Sex is very taboo. Lack of sexual health education. We don't see a lot of that in the South. And also, more Black and Brown people typically live in the South. And Black and Brown people are disproportionately impacted by HIV significantly, which I'll go back into the next slide for that. So big HIV health-related disparities. Gay, bisexual, or other men that have sex with men account for up to 67% of new HIV diagnoses, which I thought that would be higher, but that's still a disparity nevertheless. Even though heterosexual contact only makes 21% of HIV cases within the United States yearly, 54% of them are Black women. However, HIV is not always deemed to be a everybody issue. It's just deemed to be a gay quote unquote disease. As we talked about earlier, in terms of the origins of HIV, it was considered to be grid, but it impacts so many people more than gay, bisexual men that have sex with men. And again, 54% of heterosexual contact comes from or impacts Black women. People aged 13 to 34 account for 56% of new HIV diagnoses. So our youth, people are acquiring HIV and being tested for HIV at a very young age. Again, I was diagnosed with HIV at 20. I'm 30 now, so yay medicine. Shout out to them. But I was diagnosed at 20. I was relatively young, and I thought my life was going to be completely different from what it is now. But now here I am talking to y'all about how we can integrate these services into our regular everyday practices. Black and Hispanic communities make up 70% of HIV diagnoses, and 17% of people living with HIV experience homelessness or unstable housing. And that can be for a lot of reasons, right? Discrimination is a big thing. Lack of job security, food insecurity. Also, stigma impacts mental health. It's traumatic. Okay, so that's another reason why that could be the thing. HIV in Texas. So if Texas is the fourth highest state with HIV, people living with HIV. Remember I told you the South makes up over 50% of it. Well, Texas is the fourth out of the South. So 102 plus thousand people. I was tripped up on my words, but over 102,000 people are living with HIV in Texas. Just living. That's not even including people who are undiagnosed. In 2021, over 4,300 people were diagnosed with HIV. That's new cases. Within those 4,300 people, about 1,900, almost 1,900 people were diagnosed at the AIDS stage. So they were at advanced HIV at that time. More than half, 61% of HIV cases appeared amongst gay, bisexual men that have sex with men, whereas heterosexual contact made up 23%, and intravenous drug utilization was shown to show up 9% of those cases. Highest burden here: Harris, Dallas, Bexar, Tarrant, and Travis County. Dallas, we know Dallas. Bexar, I think that's like Houston or San Antonio. Right. I'm sorry, Travis is more like Houston area, and Tarrant County are some of the highest burden areas in the city of Texas. All right, so we got through what the snapshot looks like, clinical presentations, a little bit of epi, a little bit of virology, not too much. Hope I didn't overwhelm people on there. But now we're going to talk about routine HIV screenings and the recommendations. Okay. So, HIV testing in the United States. There are over 1.2 million people living with HIV. However, 13% of those people do not know or are aware of their HIV status, which contributes to 40% of new transmissions here. Okay. So that is the main reason why I'm here today, is so that people can know their status. But people cannot know that status until we routinize HIV testing, HIV prevention, treatment into our everyday workflows. Again, I know it's difficult, but this is the main reason why I'm here today. Only 3 out of 10 US adults report ever being tested for HIV. And then in Texas, approximately only 18.9% of people who are living with HIV know their status, or they do not know their status. 18.9% of people who are living with HIV do not know their status, have not been tested, have not been diagnosed, have not had a clinical work, which is higher than the national average. So again, we see that disparity within Texas in comparison to the rest of the United States. I was going to do a poll, but for people who are virtual on there, if y'all see this question, y'all could just type it in there. I'd like to know everybody's input. But what reasons do you think stop people, actual clients, people, everyday people, from getting tested for HIV? Fear.
The resources not knowing where to go test it. Access.
I would also think arrogance, being like, I don't need to get tested. There's no way I have it.
So like susceptibility.
Yeah.
Susceptible.
You don't want it to show up, the stigma, you don't want it to show up on your billing or on your insurance or your medical record.
So fear of somebody finding out, whether it be someone personally or professionally, healthcare insurance claims, stuff like that.
a regular STI screening and it's not.
Yeah, a lot of people say they get their blood drawn, so that's I got tested for HIV. I'm good. But in reality, they're not. They're tested for other things.
We got-
panels, cholesterol, like things of that nature. But a lot of times HIV is not found in that panel, which is enough. So
It's a cost of the insurance company, so.
yeah, it used to be. However, ACA makes routine HIV testing available to patients at no cost share at least once a year. Okay, so as long as it's part of the routine workup, the patient shouldn't pay anything.
Someone in the chat said denial.
Denial, yes. Yes, denial is a big thing. Y'all are hitting on a lot of things that are going to be brought up in the next couple slides. Denial is a big thing. And if y'all let me know on the chat what's popping up there, that could be a thing too. But all these things are valid for reasons why people do not get tested. You know, it's the next one. Next one.
Oh, okay.
No, you're good. It does 2 slides for what it should show results with. So why do you think healthcare providers do not recommend testing for HIV?
And they don't explain it. Deal with it.
They don't. Yeah.
It's lack of knowledge.
Arrogance, they don't want to have to do it.
I mean, healthcare providers are not, they're stigmatized too, you know what I mean? Like,
Right.
they also may not know enough about HIV to feel comfortable. Like you talked, your first question was comfortability, right? So they might not feel comfortable enough to be able to provide an educated resource for them once they find out that they do have HIV.
That's all valid. That's all valid.
Not their area of expertise.
Not that, because doctors, they're not all infectious disease specialists. They may specialize in something else like family medicine. That doesn't seem very familiar with people.
No.
Right.
Right.
We're in Biobill too, so right, upsets may be a really uncomfortable topic to do. So it's also something to consider too. Anybody in the chat say anything?
Nobody said.
Nobody. All right. So we'll talk about the core components that are about routine HIV screening that was recommended by the CDC. Now, before 2006, people only got tested for HIV if they exhibited symptoms, if they asked for it, if they were deemed to be high risk. And most of the time, a lot of intensive risk reduction counseling was supposed to be done with testing if they were to administer testing in a primary care setting, hospital setting, whatever the case may be. However, that's very stigmatizing when you think about it. Because if you're looking at somebody, and I'm like, oh, you look like you do a lot. Like you look like you get down, which everybody gets down for the most part. Everybody has sex; it's a very natural thing. And it only takes one act to acquire HIV or an STI. So again, that was very stigmatizing. But to routinize HIV screenings, CDC recommended that we, as clinical providers, as people who administer these tests, provide tests for everyone from the ages of 13 to 65 to receive at least one routine screening a year. Like I said, the ACA does allow people to get that one screening per year with no cost share. So they recommend that you do that in an opt-out basis. I know I'm skipping some of these, but they recommend that you do that in an opt-out basis. And they recommend that anybody that has tested positive for TB or had STI history also get tested as well. Now, some people on the call may not know what opt-out testing is, but essentially what opt-out testing is, or opt-out fashion of testing, is that it's just integrated into your blood work. Okay, so when you sign that consent form to get your blood drawn, and you're testing for everything else like your cholesterol, your triglycerides, your blood glucose, everything like that, an HIV panel is also done as well, unless the patient opts out. It is recommended that you have that conversation with the patient to let them know you'll be testing for HIV along with the other things that you're talking about, but it's up to them to opt out of testing rather than opting in, which is kind of how we did it before. But essentially, you're just integrating that into the normal workup so people get one testing a year, and that's basically what the recommendations are. However, a lot of providers are not doing this. And we'll get into the reasons why a little bit soon, but we'll go to the next slide to discuss. more of the rationale behind routine HIV testing. So it's as simple as 1, 2, 3. Typically, you can get early detection of HIV if you routinize HIV screenings in your practice. Again, people may not ask for HIV tests. People may not think they're susceptible to an HIV test. A lot of people may not think they're exhibiting symptoms. However, if you routinize HIV testing within your system for people that you are seeing, you may actually have a positive result. You may actually identify early cases of HIV so they don't progress to that AIDS stage. Okay, you might pick up some acute HIV infections that someone that was going to another clinic who was not routinizing that may not have picked up. So that early detection is really important. Improve quality of life. So when you routinize testing, even if that test is not positive, if you're routinizing HIV testing, you are kind of opening the floodgates for people to access other services as well. Prevention services, treatment services, support services, education, counseling, whatever you want to talk about, you're just opening the floodgates, and we call that equity for a lot of people. Especially when you're working in a lot of these rural, remote areas that people don't have these services, that education is imperative, and stigma is high in rural areas. I have worked there. There's a lot of misconceptions there that need to be addressed with routine testing, and it allows for a lot of education research and resource navigation. Lastly, if you do get an early detection of HIV, you can very much so prevent the spread of HIV to others. We're going to talk about this a little bit more, but when you get someone detected for HIV and you get them treated as soon as possible, you are more likely to reduce that person's viral load to a point where it's undetectable, where they can't transmit it via sex. And other modes of transmission too, but U equals U, which I'll talk about a little bit more, is only about sex. Next slide, please. Shoot. This is kind of confusing, so bear with me a little bit. But perceived barriers to HIV testing as ranked by healthcare professionals. This is how healthcare professionals perceive their clients. So I went over this. I'm like, that could be confusing. But this is how healthcare providers perceive their clients. They typically say that most people think HIV is a death sentence, so they don't want to find out or get tested. Which y'all talked about that. The fear aspect, the stigma aspect. People don't want to know because of the stigma associated with it, and people are not educated about how treatment works and how life continues to go on and be a quality if they do know their HIV status. Some clients will refuse HIV testing because they are married or in monogamous relationships. Yes. When I was found out I was living with HIV, I too was in a monogamous relationship. But was that person monogamous to me? No. All right. So just because you are married or in a monogamous relationship does not mean you are immune to HIV. They do not always feel comfortable having the sex talk with me, which you can't really assess someone's comfortability if you don't ask the questions. So a lot of times people will just forego that conversation because they deem it as uncomfortable, but don't have it, which is harmful to a lot of different people. And to our community separation. This is also rather confusing, so I'll break this down a little bit, but perceived barriers to HIV testing as ranked by healthcare professionals. So again, they're basing this off of what they perceive their patients to be barriers. Mm-hmm. So we're going to start from the bottom up because they rank these most important to least important. Mm-hmm. I don't know why I touched my screen. But from the bottom up, they're afraid that their clients are going to be afraid of the results if it comes back positive. And that's why they forego routinizing HIV screenings. They don't know how to handle that. They don't know how to handle the reaction, the emotional distress that comes with that. So they just don't do it. They think that their clients, if they ask them to, or they routinize HIV testing, it reflects bad on them as a person. But if you're routinizing HIV testing for everyone and you let people know that, it's not pointing to someone or pointing to you as you need an HIV test. I do this for everyone. They feel like they're going to be judged by their healthcare professional, which that makes a lot of sense because, you know, as a queer Black man, I don't really know how my healthcare provider is going to perceive me as an LGBTQ plus person if I tell them what type of shenanigans I've been getting.
Do you care?
Me personally, at 30 years old, I don't. But I know a lot of people younger me was not comfortable with that. So again, as healthcare professionals, we have to try our best to create safe spaces for our clients to have that open dialogue, which again, I'll talk about that in just a moment. Concerns about others who would find out if they were positive or even getting a test. Why are you getting a test? You out there being this, that, and the other. Well, yes. That's why I'm here. But also it's just a thing where if people do find out that you are living with HIV, again, discrimination and other forms of, oppression reside where people are unsafely housed, cannot get work, things of that nature, family may disown you, they're just not educated. That's a reality. Not feeling at risk. We talked about that. People do not feel like they're susceptible. They won't get tested. Afraid of testing procedure. I've read this article so many times. I don't know what that means. I've never been afraid of getting a test, but maybe some people don't like to get their blood drawn.
Mm-hmm.
That might be a thing. Cost, perceived cost. A lot of clients feel like they're gonna put out money for this. Again, if they have private or public health insurance, that typically is covered. Typically covered. But even if they don't have that, there are safety net programs like the health department that can provide testing at no cost. And not knowing to receive specialty care. Providers and also patients do not know where to go and receive care. But if the provider does know, we can include referrals in there to infectious disease providers or safety net programs to get through the service that they need. Next slide. Perceived barriers from the patient aspect of things. Again, a lot of these intersect, so I won't go into them too much, but cost is a big thing. Not knowing where to receive specialty care, not feeling at risk. I thought that would have been up there. Because when I got tested, I didn't feel like I was at risk. But, concerns that HIV testing may flip bad as an older person, concerns about being judged again by their healthcare provider, afraid of test results, which I know that would be up there more, but concerns that others may find out, and afraid of testing procedure. They're not like getting their blood drawn, y'all. But again, there's a lot of intersectionality here, so I won't get into that again. But just no, you're good. These are just some of the identified barriers on both ends. So recommended HIV screening tools, right? So what do we use to detect HIV? I will start from the bottom and work our way up. So with antibody tests, typically you see these with our rapid tests. You can get these over the counter. You can go to a health department and get a rapid test done. One example of one that you can get over the counter is like a Ward quick test where it just swabs your mouth and you get your results within 15 minutes. That is typically an antibody test that's done orally. However, if you go to a health department or any other provider does a rapid test, it's usually a finger prick. I know our health department does do rapid tests through venipuncture, but most of them are your finger prick. Again, they just test for AGG and AGM antibodies, okay? That's it. And then you have your antibody and your antigen test, which not only tests for the antibodies, but it also detects the P24 antigen that is very, very unique to HIV. It actually makes up some of the capsule on the HIV itself. So it detects for both the antigen and the antibody, okay? This is more so our confirmatory test that we like to do to confirm rapid results to your antibody tests. So we typically run those if we do suspect or we do have a positive preliminary result. And then your nucleic acid amplification test, our NAT test. So this detects for HIV RNA. Remember, I told you the thing that makes up HIV, the capsule, is a single-stranded RNA, right? This will detect HIV directly. And this is really, really good for acute HIV infection. So if someone comes in and they're exhibiting symptoms of, flu or whatever the case may be, and they're just like, yo, I just had sex a month ago. I just started feeling fatigued. I'm out of there. You are probably going to want to run this test to make sure that we pick, because we'll talk about window periods in just a moment, but these two tests would not pick those up. But this NAT test will. So those are the recommended screenings for HIV. Okay, I wasn't at a poll here and I forgot to take the slide off, but we're gonna move on. That question was gonna ask you what the general window period is for all tests across the board. Typically, what I tell people, because I don't know what test they're gonna get when they go to a healthcare provider. So typically I tell them like the window period is 3 months. Okay. It's gonna be 3 months most of the time. And the window period, just to explain that a little bit more, the window period is basically the time in which you have HIV. And then the point of where like the test will pick it up, right? So if you have a test that has a window period of 90 days, let's say I had sex a month ago and I'm exhibiting symptoms, yada yada yada. If you give me an antigen antibody test, that test probably or may say negative, although I actually do have HIV. But that's because the window period is 3 months, not the 1 month ago that I had sex with somebody that needed certain first. So most tests have that 90-day period. Rapid antigen antibody test, regular antibody test. Typically, those window periods are 90 days. They do have a minimum maximum, but I typically say 90 days here, just to make sure we're covering our bases. Okay. When you get to the regular antigen antibody test, which is done usually through venipuncture, that window period, according to the CDC, goes down to about 45 days. But again, I typically lump this up with this and just say the window period is 90 days. Because again, it could be variable depending on the person, how the viral load is and be detected on a test like this. Okay. Now again, nucleic acid test typically is a month window period. We even say at the health department 2 weeks, which I have tested somebody who said they had an exposure 3 weeks ago to someone who was known to have HIV, and it did pick it up. However, we'll say in this case for nucleic acid testing, it is 30 days for that window period. Hopefully that makes sense to people in there. So this is the window period. So when we're testing for people living with HIV, it's all about what you assess at that point in time. If someone says that they had recent sexual exposure, or if someone did have sex recently and they're exhibiting symptoms, I would run this test on top of these tests too, because we do have an algorithm that we want to do. But let this be one of the tests that are part of your panel. Okay, so we'll go to the next
How
slide.
do they compare cost wise?
That is a great question. In terms of cost, we can go back real quick. So in terms of cost, so typically, actually no, let's go back to the other slide. I'll talk about the algorithm real quick and I'll break it down for you. So typically, when someone comes into a healthcare facility, you start with the antigen antibody test. Okay, you start with that. Okay. Typically 9 times out of 10, that will pick up. We like to say an antigen antibody test is about 95% accurate, given that window period. Typically, this is the one that's covered at no cost share, right? However, if someone were to test positive, right, you have to do what we call an antibody differentiation test. Remember, I told you there's 2 different types of HIV, 1 and 2. This will differentiate which HIV that person has, either 1 or 2. Most of the time in the US, it's going to be 1. Okay. Typically, because of the algorithm, if it is positive and it goes to this algorithm of doing another confirmatory test, that will also be covered. Because you're confirming these results, that should be at no cost to the patient. However, if you do need additional testing and you're not sure if your insurance is going to cover it, just send them over to the health department. We'll take care of them. We'll run these tests. It's no big deal. But let's say it was positive, they're going to differentiate which HIV it is. And then after that, a lot of times you may have an indeterminate test, which is very, very rare. But if you have an indeterminate test, it will ask the lab to run a NAT test, which will then determine if you have an acute infection for positive HIV for HIV2. Now, if this is negative, there have been instances, this algorithm, I could do a whole presentation on this, but there have been instances where I've had a false positive. And then we run a NAT and it comes back to be negative. And I hate the fact that sometimes I put people through this, and me and Anish, we've had that situation recently where someone had a positive HIV rapid and we went through this algorithm and it came out that that person was negative and we don't know why. We don't know why. It's hypothesized many reasons why that would throw that off, but we do this algorithm to confirm that that person actually is living with HIV. So yeah, that's. But to answer your question, based on the results, the labs will have to run this, and it shouldn't be at no cost to the patient. HIV screenings for pregnant people. I say pregnant people because not all women bear children. It's an inclusive space. So with that being said, HIV screening should be conducted as soon as possible once a person is entering prenatal care, and then in the 3rd trimester of prenatal care. Usually before 36 weeks of gestation. Okay, we want to do it before then, right? The reason why we want to test before 36 weeks is because we want to administer medicine as soon as possible, not only for to not only treat the parent, but also prevent transmission to the baby. Okay. Which again, well, I'll go into that a little bit deeper when we get to the treatment section, but that's the main reason you want to do it before 36 weeks. HIV testing should be done at labor as well. A lot of people do not have prenatal care, so they just go straight to the hospital. I've been carrying, pop the baby out. They at the hospital, they get tested. You need to get tested there too, but not everybody has access to prenatal care. All right, the baby should also be tested as well. And then individual test positive should be referred to treatment as soon as possible to again reduce viral load for the parent, but also to prevent transmission to the baby. All right, HIV prevention. We're gonna talk about PrEP and embed. Again, I did have stuff, but we're gonna just talk through those polls, not necessarily go through the V-Box. All right, so pre-exposure prophylaxis, that is short for PrEP. I like to call this the birth control for HIV. Okay, because you take it every single day and it protects you before you're exposed to HIV. It just so happens you're having a wild night, not even a wild night. Let's say you even like you're with somebody and y'all don't get tested together, and you're exposed to HIV. You are protected as long as you take it every single day. There is both an oral and an injectable option for people who want to get on PrEP. When we talk about the 99% effectiveness rate, we do talk about oral PrEP, but injectable PrEP is also highly effective. But again, PrEP is only as good as the person that has access to it and as adherent as they are to it. Okay, we want to make sure that when we discuss PrEP, it is an option to prevent you from getting HIV, but it does not prevent you from getting STIs and/or unplanned pregnancy. However, you can be pregnant and you can take PrEP. Okay, just don't prevent those things. So if you need that, you need birth control as well. It's fine. All right, who should be offered PrEP? This is CDC's list. Okay, have anal sex within the last 6 months. You have a partner who is living with HIV, who isn't virally suppressed, isn't on treatment. You may not use condoms all the time, which who does? Nobody. You haven't diagnosed with an STI in the last 6 months. You have an injection partner with HIV. You share needles. You have multiple courses of post-exposure prophylaxis, which we'll talk about that a little later on. However, hit that slide for me. Everybody should be off of PrEP because everybody is participating in some form of behavior that could transmit HIV, especially if you're having sex. So if you are doing your assessment on somebody and they are known to be having sex, even if it's like once in a year, you should be getting them screened. You should be talking about PrEP because again, it only takes that one time to get an STI or to get HIV. So everybody should be screened and offered PrEP. Yeah. Now, when we talk about oral PrEP, there's 2 types of oral PrEP that are available on the market. I'm only going to name these by brand names because if we get into the pharmaceutical names, it loses me, okay? But 2 different oral PrEPs that are available. There's Truvada and Descovy. Both of them are FDA approved. Both of them are graded A in terms of the United States Prevention Service Task Force. They have a grade A recommendation, which makes it available at no cost share for people that have private or public insurance. But also, safety net programs are available to get people PrEP if they don't have insurance. And they're both single tablet regimens, 1 tablet a day. However, the main thing that's different between these 2 is that Truvada was clinically tested and approved for both male and female assigned at birth. Descovy, however, was only clinically trialed for those who were assigned male at birth, which actually causes quite a misconception in terms of like PrEP utilization amongst everyone. Because a lot of women that I talk to about PrEP only see commercials for Descovy. I know you've probably seen them. I'll be watching the Super Bowl and I'll be watching my favorite shows, and next thing you know, boom, Descovy. And I'm just like, oh, snap, this is amazing. Because in 2014, 2013, this was not a thing. However, because people only see the Descovy commercials, they only see men represented in these or trans women represented in these commercials. Cisgender women do not think PrEP is for them. However, there is an option for them in terms of oral and injectable PrEP. So that's the only difference. Speaking of injectable PrEP, Apretude, This is a very, very new recent biomedical intervention that allows you to get injected PrEP in your buttocks every other month and give you that same surefire protection without having to take pills. Okay. It was FDA approved in 2021. It is approved for both men and women assigned at birth, weighing up to 77 pounds. That's for this right here is for both oral and injectable PrEP. The only thing about this is that access is very limited because it's a new biomedical intervention. A lot of times prior authorizations are needed, and that is because they're not on everybody's formulary. So it makes it very, very difficult to access. However, I can't really specify who is the pharmaceutical behind this, but the pharmaceutical company does have patient assistance programs to get this to people who do need it. Okay. So I don't want you to think that you can't get it to them. It just may not be a thing that your practice may have time to really navigate through for the simple fact that prior authorizations and talk to the health insurance company, well, it's cumbersome. It's a lot of work. So this is something that is still brand new to the market, but it is available. You start off with 2 injections, both back to back within 2 months. So let's say I come in, what's today's July, right? We'll start with August 1st. Let's say I come in August 1st. I want Apertune. Ooh, well, test me first. Test me first, make sure I'm negative. And then like, okay, cool. You're eligible for Apertune. Inject me in the butt August. I come back again instead September, yes. Inject me in the butt again. And then I don't come back and see you again until December. Ho, 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 Merry Christmas, inject me. All right. So that's how that would work with Apertune. And again, you get an injection every other 2 months. And this is the alternative to taking a pill every single day. There are new studies about a new medication that's coming out that's for injectable PrEP. I did not include that in this, but it is an injectable option that's being clinically tried for every 6 months, which would be a game changer. But I did not put that in here because it's not FDA approved or anything. So
When would you start getting the actual protection?
that's a good question. So typically, with Apertune, so I'll go back to oral PrEP and I'll talk to you about that. But oral PrEP, if you partake in anal sex, the protection is usually shielded within 7 days. Okay. If your participation in vaginal sex is 21 days. But typically what I tell people that I wait until 30 days to make sure you maximize that protection in that safeguard. Injectable PrEP works a little bit quicker than that. I've read for injectable PrEP, it can be anywhere from like 7 to 14 days where you get maximum protection against all modes of transmission. Okay. So it just depends on which one you're taking. But typically I just tell people wait 30 days. Just wait 30 days and then you're good to go. Make sure you take your medication as prescribed even after that 30 days. Side effects. So if you are talking to somebody who is taking PrEP, there are some side effects that may be discussed during your interaction. A lot of these are gastrointestinal. So we talk about diarrhea, we talk about nausea. Typically that's only really seen. I was actually surprised by injectable PrEP giving you all these side effects too, especially when it comes to gastrointestinal. But with diarrhea and nausea, what I typically tell people who are taking the oral PrEP option, because unfortunately we do not offer the injectable option in the health department yet, so we're working on it. With oral PrEP, what I tell people about the diarrhea and the nausea, I typically tell them to 1, take it at night and or take it with food. That kind of helps with that nausea aspect of it. Definitely helps because you're introducing a new biomedical intervention to your body. You're going to experience these side effects. Headache and fever, again, you're introducing a new biomedical intervention to your body. It does take some time for your body to get used to it. So typically I tell people, again, take it at night, maybe pop it with an ibuprofen, and just let your body get used to those new introductions to the body. Sleep disorders and dizziness are also to be reported too. And although 5%, 4%, all these different variables do seem like a lot of these do get better over time, and some of these don't happen at all. But I just want you to be aware of each in case they are brought up in conversation. However, for injectable PrEP, a lot of people, 75 to 82%, because you are getting the injection in your buttocks area, you do have site reactions to that. Redness, swelling, induration are some of the key side effects that come with injectable PrEP. what I tell people about that is that I tell people that like a warm compress will help there. Like if anybody asks you, say you had a hard day, you just rest your hand on your butt with a hard compress. And then you could take like ibuprofen to help with the swelling, the induration, things of that nature, and that should help. Now that happens not every single time, but when you first start injectable prep, you will experience side reactions. But after a while, you get used to them. Sometimes they may go away without any other interventions. You should be fine. Some more prep side effects. So a part of your prep care, it does require you to do labs consistently to check for these things. One of the things that we're going to check with prep, I should have put this before, but I'll talk about it now. But some other side effects deal with your kidney functioning. The medicine that's in prep with special emphasis of Novavir does impact the kidneys in the liver because you're taking it every single day. And these are also the same medications that make up treatment for HIV. They just have impacts on our liver. They're filtering out through our bodies. They have lots of medications that are high impact to the kidneys and the liver. But these are very rare. We want to make sure that our creatine levels are no less than 60 for oral prep and 30 for injectable prep before we start somebody with prep. Because if you're already experiencing low kidney functioning, it's not recommended to get someone on prep. So you may want to discuss with them other options. Bone density. This is rare. However, there are clinical studies that show that people's bone density does decrease significantly with oral prep. This is also exacerbated if someone does have pre-existing conditions like osteoporosis that already impact our bone density. However, this is reversible. So if someone does stop using PrEP, it does get reversed within 6 to 18 months. And then lactic acidosis, just with any type of biomedical intervention, we do experience an increase in lactic acid, which does contribute to symptoms such as fatigue, nausea, weight loss, and vomiting. If someone that you are talking to is experiencing lactic acidosis, please cut off all biomedical interventions, especially if they don't need to be. Baseline labs for testing. I'll go through this really quickly. With PrEP initiation, you want to make sure that they get tested for HIV. If they are negative, they are eligible to go. Boom. If they are positive, you do not want to start someone on PrEP. The reason why I say that is because if you start someone on PrEP and they're positive for HIV, even if they are not negative at baseline, but you see them every 3 months and they seroconvert to being positive, you want to switch them to an antiretroviral therapy that treats HIV, because if you continue to put them on PrEP, it causes resistance to antiretroviral therapy. So HIV testing is always supposed to be done at baseline and during ongoing monitoring, which is every 3 months. STI testing, we want to make sure we get testing for chlamydia and gonorrhea and our syphilis. With chlamydia and gonorrhea, you can do site swabs orally, rectally, vaginally. But if you're doing a vaginal swab and you do a urine collection, you don't have to do a vaginal swab, but you can do on-site swabs. For syphilis, TPPA testing is the recommended standard. Treponema pallidum particle agglutination test is the test that we recommend. RPR, I forgot what that meant, but that essentially tests for your titer. So if someone has an existing syphilis infection, you might want to run that titer to make sure there's no reinfection. Hepatitis B and hepatitis C testing. So there's a lot of research about this. In terms of people that have Hep B in particular, the medicines that are used to treat Hep B are also utilized in tenofovir has been shown to prevent Hep B, actually, in a lot of research studies. But it's not recommended for people with active Hep B to get onto PrEP, because if they do not know their Hep B status and they're just taking PrEP and they're like on and off of PrEP, because sometimes people are on PrEP for a season, not for a reason, and they may cause flare-ups with their active Hep B infection. So providers kind of go back and forth with this. I kind of wish I had a provider here to discuss this a little bit more detail, but providers sometimes are hit or miss if they want to prescribe PrEP if they have Hep B. But because of some other research that's being shown about how PrEP can also prevent Hep B and also treat Hep B, that may be something a provider may want you to actually continue if you do have Hep B. Other labs include kidney functioning, creatine. And also lipid panel to test for HDL, LDL, cholesterol, triglyceride, and other bodily. After baseline, typically you do see PrEP patients every 3 months. And you test for HIV, STIs, pregnancy, and you want to assess adherence, change behavior, and side effects. Because if someone is going through the ringer, you want to discuss that with them to keep them on PrEP. And if they're unbearable, you might want to discontinue PrEP. But you want to do this every 3 months. If that test is negative, they feeling well. If they do test positive for STI, get them treated for it. But as long as that test is negative, you can continue someone with PrEP to make sure they have that ongoing protection. Then every 6 months, you want to make sure you monitor kidney functioning. Again, if they already have decreased kidney functioning, you might want to do that more rapidly, maybe every 3 months. Some providers just throw that into the panel. It just really depends. And also lipid panels are also done too. So reasons to continue PrEP. I want to put an emphasis on choice and autonomy. Okay? Because we need autonomy to our bodily functions and what we decide to do with them. If someone does not want to start PrEP, if someone does not want to continue PrEP, or if you have somebody that's living with HIV doesn't want to start treatment, unfortunately, it's not our power to force them to do it. But when you're having conversations with people, these can be, motivating factors to keep them on PrEP. So it fosters peace of mind. You don't have to worry about HIV when you're having unprotected or condomless sex. STIs are still a thing, but you could have sex in all the liberating and wonderful, pleasurable sex you want to and not have to worry about HIV. Okay, so it gives you peace of mind. Again, it gives you access to routine testing, counseling, and education. So if they're always coming into their appointment, they have access to these things on a continuous basis. And depending on what setting you're working in, this may be their primary care for the most part. So you're engaging them throughout the continuum of care. It prevents HIV acquisition amongst serodiscordant couples, where that person who is living with HIV may not be virally suppressed or may not know their status. Is user controlled and concealable with both the pill and the injectable options. A lot of people don't need to know you're on PrEP because you could put the pill somewhere in a safe keep, or you can get the injectable option where no one can see that you're getting it. It also just empowers you to take your own sexual prowess into your own hands. Kind of goes into the peace of mind part. But again, to discontinue PrEP, if someone wants to discontinue it, you can't force them. That's their choice. Let them. Clients that's positive for HIV, discontinue. Get them into treatment. Again, we don't want to cause resistance. Clients experiencing renal complications, active hepatitis B, inability to come in for their appointments or injectable PrEP, and also allergic reactions and or adverse side effects, which I kind of already touched on. All right, so now we're done with the PrEP section. Now we're going to talk about non-occupational post-exposure prophylaxis. I call this the morning after pill for HIV. Okay, so where PrEP was the birth control, where you're taking something continuously to prevent HIV, post-exposure prophylaxis is something that you take after you have a confirmed or presumed exposure to HIV that would prevent you from getting HIV otherwise. Okay, so again, MPEP is an antiretroviral therapy that is administered to a client after a possible exposure. It is to be administered to a client within 72 hours of their known exposure. If it's anytime after 3 days, MPEP is not really going to work at that point in time. What I would recommend for somebody that you can't get in after 72 hours is just recommend testing for them to come back in for testing within maybe a month or two to make sure that they did not seroconvert and you catch that acute infection as soon as possible to get transferred into treatment. MPEP, I already talked about that. Once it's prescribed, you do have to take it for 28 days. After 28 days, you're good. You'll come back in for follow-up testing and everything like that to ensure that you are still negative. And studies have shown that the use of MPEP demonstrated 100% effective efficacy after being administered after 24 hours, and it decreases after 48 to 72 hours. But again, you could not administer it after 72 hours. Initiation and follow-up, very similar to PrEP. You want to make sure that this person actually has an exposure. If someone tells you that they hugged someone living with HIV, do not give them MPEP. Okay.
It's raped her or something, she doesn't know.
Absolutely. Sexual assault victims are typically prescribed embed, especially in emergency room hospital settings. Absolutely. Administer PEP, no ifs, ands, or buts about it. Administer PEP. Someone comes to you and says, "Oh, they hug Brian, get them out of here." It doesn't work like that. And again, okay, yeah. And survivors of IPV, sexual assault, and other forms of coercive sex should be prioritized. Lab initiation, we do HIV testing, kidney functioning, Hep B, Hep C, pregnancy tests, and then follow up in 72 hours and up to 4 to 6 weeks after starting MPEP to make sure they're still negative, do more testing, and do more Hep B, Hep C.
Does that judge affect if someone is determined to be pregnant?
No, not at all. If someone is pregnant, they can take both MPEP and PrEP. Again, summary. Birth control for HIV, or an after pill for HIV. Just a cute little summary. All right. So I have some case studies for you, which we're going to run through pretty quickly, but we're not going to utilize VBox. You're just going to answer those questions for me. People in the chat, you could definitely just put your answer in the chat if you would like. So, a 27-year-old same-gender loving male enters your clinic with good health and looks to establish care. However, he isn't feeling well and is showcasing post symptoms like fever, sore throat, and swollen lymph nodes. He reports having unprotected anal sex with his main male partner and 2 occasional male partners. So he got himself a roster. You order a test, and his HIV-1/2 antigen antibody test is negative. He shows interest in PrEP. What are your next steps?
Send in additional net and testing it and viral load.
Anybody else oppose that? That was a little bit of a question. But yes, you wouldn't want to initiate him on PrEP because, of course, he's exhibiting acute HIV symptoms. You don't want to wait for his cold to improve to start him on PrEP because, again, it could be seroconverting. And you don't want to start them on MPEP because, again, if you give someone antiretrovirals that are not meant to treat HIV, you're going to cause resistance. So B would be the best answer. I'll check the chat. So go ahead. This would have shown. Oh, this is another one. Okay, perfect. So a 22-year-old trans woman presents with discharge into your clinic. She reports having multiple male partners with inconsistent condom utilization. MAT testing shows positive for gonorrhea, and she receives treatment, so she's adequately treated. At her follow-up, you suggest PrEP for HIV. She is interested, but concerned that PrEP may interact with hormonal therapy. Actually didn't discuss this, so this is actually just going to be a real good guessing question. What would you inform this client? Would you inform them that estradiol lowers the concentration of PrEP, so the dose of PrEP should be doubled? PrEP lowers the concentration of estrogen in the body, so her estradiol dose should be maybe to be increased. Use of PrEP along with hormonal therapies is not recommended. Or there are no known drug interactions between PrEP and cross-sectional hormonal therapy.
How about D?
I think yeah.
Yeah, go with D because you said earlier that, people that were male at birth could take the Truvada,
Absolutely.
or they could take the,
Discuss it.
Diagnosis.
Right. That's so smart. There is no drug interaction between hormonal therapy and PrEP. So you could definitely, when it comes to trans women who are on hormonal therapy, you could definitely prescribe PrEP to them. So yes. A 45-year-old, a cisgender female, is referred to you after being treated for chlamydia. He reports having 1 to 2 new sexual encounters per month, all male partners. Her clinical workup is, I was supposed to put unremarkable there, my bad. And she tests negative for HIV-1/2 antigen antibodies. Her last sexual encounter was approximately 2 days ago, unprotected anal sex. How would you manage her care moving forward? Would you send in a HIV viral load and start PrEP if it's negative? Wait 4 weeks and recheck an HIV antigen antibody test and initiate PrEP? Would you start on PrEP immediately, or would you start in PEP and transition to PrEP after 28 days?
And PEP and PrEP.
yeah.
But wouldn't you still do the NAT test? Like
You
you
can
would
do
say
both.
for
This is
NAT
actually-
as well? So
that's
does that
actually-
ban that?
That's real. That's real. You borrowed. We're gonna forget the second part. And we're gonna definitely do the HIV viral load test. Yes. But you definitely want to initiate them on embed, and then once that goes, you want to retest them again after 28 days, and then talk to her about. All right. So a work of art, which is short for antiretroviral therapy, in terms of we're talking about HIV treatment and care. So the basic science. So typically, treatment once upon a time ago for HIV was terrible. AZT had more adverse effects on the body than it did helping. However, since then, now we're in 2020s, 21st century. A lot of our HIV treatments only require at least one pill a day that consists of most of the time 3 medications, 2 reverse transcriptase inhibitors, and then usually it's tied with an integrase inhibitor or a protease inhibitor. Okay. Again, I only showed you the life cycle before because those are the 3 enzymes that cause HIV to to infect the host cell. But what those do is that they integrate those medicines to help reduce the viral load and improve our CD4. Okay. So if taken as prescribed, antiretroviral therapy reduces the amount of HIV in a person's body to an undetectable viral load, which means that they cannot transmit HIV to others through sex. There's other modes of transmission that, being undetectable does help out a lot. But when we talk about the terminology U equals U, which is undetectable equals untransmittable, there is effectively no chance of transmitting HIV through sex. Meaning the person living with HIV can have all the kinds of sex in the world, have babies, do whatever the case may be, and literally eliminate their chances of transmitting HIV to their sexual partners or to their child. Okay, so when we talk about that, we'll get into it a little bit deeper. I won't get into this too much. I'm not gonna lie to you. We could talk about pharmaceuticals all day, every day, but I just want to show you, case to you, how like that 2 goodness gracious, the NRTI, which is the nucleoside reverse transcriptase inhibitors, are basically seen throughout these drug regimens, and they're also tied with integrase inhibitors and also protease inhibitors to kind of create this cocktail where you're not taking 2 medications or 3 medications, but you're only taking 1 pill a day, that reduce the viral load significantly and improve the quality of life for people. This could have been like 10 slides. I'm not gonna do that to y'all. It's not a pharmaceutical course. But I just want to show y'all some of the options. Question. U equals U. I kind of said this already. Also known as undetectable equals untransmittable, means that a person living with HIV cannot transmit HIV through which mode of sex?
You said it. But you didn't say it before, yeah.
Listen, you see how I'm trying to help y'all out? It is sex. I only ask this question most of the time because a lot of people think, if they are familiar with U equals U, they think it applies to all of these. Although it does decrease the chances significantly with these other modes of transmission, there's virtually no transmission occurring during sex, which I'll get into the science of today in just a moment. A person living with HIV is considered to be undetectable when their viral load test is less than blank copies per milliliter of blood. This might be a trickier question because I did not mention this. But which choice do you think is the right choice? 20. Damn, I got one. All right, so anybody in the chat say anything in regards to this? No? Okay. So a person living with HIV is considered to be undetectable when their viral load test is less than 200 copies. So 200 copies, and that's based off the research, which I'll go over in just a moment. But although these are also considered to be undetectable, as long as you're 200 and below, you're undetectable. Okay, so we'll go on to the next slide. Again, I'm putting a lot of emphasis on undetectable equals untransmittable, just for the simple fact that this has more impact on people living with HIV than we like to discuss. It is a huge incentive to getting people into treatment, okay? Because it just reimagines what HIV really is at the core concept of it, okay? For a lot of people, HIV is a death sentence, not only for physical, but also social, mental, other aspects of their life. A lot of people think when they get HIV, life is over. They cannot have romantic partners. They cannot have children. They cannot do all these things. But the work of art, which is why I named this that, is really impactful for so many people. So again, when you have less than 200 copies per milliliter of blood when you're taking your medicine as prescribed, you cannot transmit HIV through any forms of sex, anal, vaginal, yes, we'll say oral, but any of those, virtually nothing. Okay. Although U does work in the absence of condoms or PrEP or embed, we still recommend condoms to prevent STIs and preventing unplanned pregnancy. Okay, this is not an anti-condom, this is not an anti-PrEP, this is not an anti-MPEP message. This is a pro-HIV, pro-people living with HIV message. That needs to be discussed with all your clients, really, but especially for people living with HIV. One more time. So the science. So there's 4 key research studies that basically validate this message. And I won't get into all of them in specifics because of time, but nearly 150,000 condomless acts were observed in these observational studies that showed no transmission occurring amongst serodiscordant couples when someone was living with HIV and had an undetectable viral load and someone who was negative. The reason why we talk about 200 copies is because in these observational studies, people who had less than 200 copies per milliliter of blood were not transmitted. No transmission occurred. No seroconversion happened when people were less than 200, excuse me. So this is the science that basically brought together this U message and brought it to the forefront. This is very basic, but typically this highlights kind of how soon or basically the average amount of time for people to reach an undetectable viral load when they are on antiretroviral therapy. So typically when you administer antiretroviral therapy, your viral load goes down, 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 down. If they're taking as prescribed, it goes down significantly. It's estimated clinically that 6 months is the time that most people reach an undetectable viral load. However, if you're taking your medicine as prescribed every single day, you can see that happen in 3 months, a month. It really just depends. It varies. Typically, when I talk to people about U, they can take their medicine every single day to the point where when they go to their follow-up within a month, they're already there. Like they're already in the textbook, CD4 going back up, like they're already there. But again, you got to make sure that you take your medicine as prescribed to get to this point and maintain it. Okay, because once you achieve it, you have to sustain it. You got to continue to take your medicine as prescribed. And then once you sustain it for long enough, it is, again, research study to show that you cannot transmit HIV through sex. Oh, this is a great question too. True or false? A person living with HIV who chooses to breast and or chest feed their child should not be allowed to do so, even if they are undetected.
I think that's true. They shouldn't. You saying they shouldn't breastfeed their child?
Yeah,
Yeah.
they should not. They should
You
not.
know they. Yeah, because you just said earlier, if they undetectable, they only can transfer it to. It's undetectable. Transfer it to sex.
What does everybody else think?
I mean, the wording of should not be allowed, that's what's getting me hung up. But
I use that terminology because a lot of people do not believe that people living with HIV cannot breast or chest feed their children to the point where they get CPS called.
I mean, if there is scientific evidence showing that it is safe,
Mhm.
who cares?
Right, exactly. But a lot of people, stigma plays a huge role as to why things like that happen and why people don't have the bodily autonomy to breast or chest feed their children. This is actually false.
Well,
So we're gonna go to the next slide.
we're not going to discuss it.
We will. We're here. We're here.
Sorry.
So, so CDC has this lovely table that I show in all my presentations that show the risk of HIV transmission with undetectable viral loads by transmission category. Again, the reason why we talk about U when it comes to sex, this shows here. Studies have shown no risk of transmission. Zero. Zilch. Not. I don't know how else you're supposed to say this, but none. But when it comes to pregnancy, labor, and delivery, it's 1% or less. Again, we don't talk about euthanasia when we talk about this because there's still a chance. Although 1% is pretty small. But when you look at this little asterisk here, it says here, the risk of transmitting HIV to a baby can be 1% or less if the pregnant person takes HIV medicine daily as prescribed throughout the pregnancy, labor, and delivery, and gives HIV medicine to their baby for 4 to 6 weeks after birth. Okay? So again, when we talk about undetectable viral loads, although we don't talk about you in the aspect of sex, it has other benefits outside of that mode of transmission. So when it comes to being undetectable, when we talk about pregnancy, labor, and delivery, less than 1% chance, we won't take those risks. Not risks, but we're gonna take that chance, right? Because that still reduces it significantly to the point where not only is the person living with HIV taken care of, but that baby is like not going to be born with HIV. They're not. Even if someone is not virally suppressed, for pregnant persons with HIV, the estimated rate of perinatal transmission of HIV in the absence of any HIV treatment is approximately 25%. Which again, that's higher. But even amongst people that are not being treated, you still have a 75% chance that baby is not going to be born to HIV. Among children who acquire HIV perinatally, about 20% of the transmission events occur before 36 weeks. That's why we talk about that HIV screening before 36 weeks. 50%, it gets higher. 50% between 36 weeks in delivery, and then 30% during active labor and delivery. Okay, so again, this reimagines everything that we talk about with people living with HIV. Euthanasia is very important to really discuss with people living with HIV because it incentivizes them to get into treatment. It dismantles a lot of interpersonal stigma and personal stigma associated with acquiring HIV, and it makes all these possibilities, well, a reality. Now, unfortunately, we still, in terms of viral load, we still don't know how euthanasia applies to sharing syringes. But when we talk about breastfeeding, if we go to the next slide, which, oh, well, we're talking about this too. Perinatal transmission has decreased significantly since 2016. If people are in prenatal care and they are taking their medication as prescribed, perinatal transmission does not occur if you're undetectable. We still have a lot of work to do, but there's still transmission happening. But from 107 to 44, we're doing better. We're on a steep climb. Now, when it comes to HIV and breast and chest feeding, recent guidance last year came out about people living with HIV being able to breastfeed or chest feed. I want to focus on this. So this is kind of like, what we were doing before. The replacement feeding with formula or banked pasteurized donor human milk is recommended to eliminate the risk of HIV completely, right? That makes sense because you're pasteurizing the milk, you're eliminating all types of things in the milk, and you're able to feed that baby. You don't have to worry about anything. That used to be the standard, right? But if you read the second bullet, individuals with HIV who are on ART with sustained undetectable viral loads and who choose to breastfeed or chest feed should be supported in the decision to do so with their healthcare provider. Engaging Child Protective Services or similar agencies is not an appropriate response to the infant feeding choices of an individual with HIV. These are updated clinical guidance from the federal government. So again, there's been a lot of research behind what an undetectable viral load can do in terms of not only pregnancy, both during and after, but it's shown that people who can bear children, who can breast and or chest feed, should be able to share intimate settings in terms of feeding their child through breast or chest milk. Okay, as long as they're undetectable, and it's a collaborative effort between the client and their healthcare provider. Okay, I know this seems really daunting and very different, but this just shows the advancement in medication in a way that allows people living with HIV to live normal and quality lives. Okay, so when we're discussing these things, you may not feel comfortable talking to this in terms of your client directly, but getting them with an infectious disease doctor that can specialize in this and how to aid them through it allows them to have that collaborative effort in terms of breast and chest feeding. So how do we get to viral suppression? I like to call it TLC, treatment, lab, and care. Okay, that should be super easy to talk to your clients, even if you're not an infectious disease specialist. We want to get you to treatment as soon as possible. Okay, we want to make sure that when you are seeing your doctor, you are getting your labs done every 3 to 6 months. Sometimes when you're living with HIV, you only see your doctor maybe every 6 months to a year, maybe depending on how adherent you are, how long you had that relationship with your provider. It does change, but you still want to make sure you get your labs done so you get your treatment. And you also want to make sure you take care of yourself. As a person living with HIV, I always prioritize self-care. And well, of course, if you're providing the services, you want to make sure you're providing ongoing engagement and support for that client to meet their health-related goals. Routine HIV treatment in the labs. This is very similar to the PrEP slide, but these are very unique to HIV treatment. Of course, we want to do a CD4 count, and we also want to do a viral load test. These two tests are indicative to make sure the treatment is working. Okay, but before we even do that, we want to do genotype testing, which genotype testing basically tests for resistance to biomedical interventions. So this test is typically done to make sure that the treatment that we're giving them works, right? Resistance is actually very rare most days in today's world with the medicine that we use, especially with them being combined with other medicines like integrase inhibitors and protease inhibitors. They are a very low barrier to resistance. However, there are still cases of people that do get medicine that doesn't work for them. That genotype testing does help with identifying which treatment regimens are best for them so that they can get their viral load reduced and their CD4 count can be rebounded. But typically, you do this every time you go to your lab for people who are living with HIV to ensure that medication is working and refills are prescribed. Okay. HIV care and treatment really starts at the beginning. So when you test somebody for HIV and there's a positive result, that's the start of HIV care. And we sometimes lose people when we deliver a positive result. Because sometimes it's not delivered in a manner that is trauma informed, that is patient centered, and that really prioritizes the client's needs. And a lot of times that could be a traumatic experience for people. And um, as a person that's been on both sides of this, giving someone a positive result and also receiving a positive result, I understand where that trauma can manifest and how it can impact people holistically. However, we as healthcare providers can do our best due diligence to make sure that we are delivering this message in a way that is trauma informed, that is patient centered, in a manner that is well, quite understandable to the client and is done so in their own language. Okay. So when you're delivering an HIV test, I always start from the beginning. I always prioritize self-care. When you prepare to give someone an HIV result, that starts before you walk in the clinic. Please remember to take care of yourselves. Remember to prioritize yourself. Make sure you get adequate sleep. Make sure you center yourself around connectedness, family members, friends. So make sure when you go into situations like this, you are prepared to be a shoulder to cry on or to be someone that can provide aid in these situations because they're never easy. And also they can cause bidirectional or even trauma that is not associated with you directly. You can experience trauma because you see someone else being impacted by this. And quite frankly, that messes people up. So self-care is important. So now that you're taking care of yourself, if you do get a positive result, you still have preparation that goes with that. You got to ensure that you do have a quiet and confidential space to sit the client down and you have this conversation with them. Because again, it's not easy and you want to make sure no one else hears it, but you also want to prepare for the reactions that may come with this. And then before you do that, you want to make sure you identify provider options to refer them to treatment once you have had that conversation in the additional moment of like surprise or trauma happens so that you can help them navigate those next steps. Okay. When you're getting ready to get the result, you want to make sure your client is comfortable sitting upright in a durable and sturdy chair. Just in case they do sway from side to side or they have a reaction where they may fall over, you want to make sure their physical health is taken into account as well in all aspects. You want to welcome the client in, offer a refreshment if you have one, and ensure the area is still private for them. If you have trust with that client, make sure that it's just a you and them kind of thing. If they need someone else to be I battle with like telling someone's HIV status with another person in there, but if the client needs that support, they pay for it. They just have to sign kind of consent forms so that they can ensure that person wants it. But provide them with anything that they need. And then when you get ready to tell them the results, you welcome it. And I would just be like, boom, you have HIV. If there's anything else that you did in terms of clinical workup, tests, labs, or anything that were done, you may want to deliver that first. And then once you transition to an HIV result, you just want to kind of sit them down, let them know, like, hey, one of your labs did come back reactive. And it shows that the result that you have for your HIV test came back positive. After you do that, you do want to let them kind of process that information. It really depends. Sometimes if the person may have already known. Sometimes even before you administer a test based on the things they tell you, you might have already kind of worked them up to getting ready to this. But sometimes if you routinize testing, you give testing to everybody, it may not be expected that this result may happen. So you may want to provide them with the process to react and provide additional support. Make sure you want to center your client's concerns, questions that they may have, and discuss options for treatment at that point in time. Give them a good 10 to 15 minutes for you. Let them talk about whatever they want to talk about. Allow that counseling to happen. Allow that emotional dump to come out so that you can kind of validate their feelings. Again, validate clients' concerns, promote benefits of medical and social support services, and help them guide them through this complex transition. Because it's not easy. Even if they do understand the benefits of treatment, you talk to them about you talk to them about how you can still do everything you want to do even before you knew about these results. You want to allow them to process and to see things through. It's not easy. There's no exact science. I did not pull this from an article. These are strictly from my experiences and some of the best practices that were taught from the state level. But this is never easy, but this is kind of like a best practice that I would abide. Next slide, please. When you do give someone a result, you want to make sure that you are setting the tone. You want to normalize HIV in a way that's stigma-free. A lot of times we may not realize it, but some of the terms that we use can be stigmatizing. I've been guilty of this as a person even living with HIV. But sometimes you want to prioritize language that puts the person first and puts the H back in HIV, which is human. So when we talk about people living with HIV, we want to use a thing called first person language, which doesn't call someone an HIV positive client or HIV infected person. We're going to call them a person living with HIV. Okay, because that puts the person first and not the disease first. But you also want to ensure that HIV is a chronic and manageable disease, not in terms of nature, because it definitely is communicable. But once you are living with HIV, it is very manageable. I've talked to a lot of people that said they would rather have quote unquote HIV than diabetes. And honestly, because you just take one pill a day and you go see your provider, you get your labs done, and you get prescribed medicine every single day, you take it once a day at that point in time. You can achieve an undetectable viral load and ensure that your life is still quality and do everything you need to do. Of course, there are some nuances to that in terms of disclosure and stuff like that. Of course, you want to promote that. But in the greater scheme of things, it is a manageable chronic condition that can be managed relatively simply, as long as you have access to services. We want to focus on mental health and coping. At the point of giving someone a result, and also ongoing throughout the maintenance of like seeing clients overall, you want to assess their mental health. You also want to assess right then and there if they have any support that they can rely on, have a shoulder to cry on outside of you, outside of the healthcare facility that you work for. And you also want to assess for signs of depression, suicide, or self-harm. And please make sure that you follow up your client within the next 1 to 2 business days of talking to them. I typically like to do it after a day, just to make sure and checking with them, and again, providing a resource navigation to get them to where they need to be. Lastly, please healthcare providers out there on the call, also here with me, please let them know that the health department's going to follow up with them. I know we have some DIS in the room right now which DIS is short for disease intervention specialist, but please let them know that someone is going to reach out to them, because the health department has to follow up with every single person who is diagnosed with HIV or STIs to ensure quality follow-up, treatment adherence, and also a thing called partner notification. This is our way of ensuring we identify the source of infection and possible spread. Because again, a lot of people do not know they have HIV and they're not spreading it purposely. That's very stigmatized to even think that. But a lot of people don't know that they have HIV. So we want to make sure we track the potential source and or spread of infection. That's what the health department does. So if you let your client know that beforehand, and we just call them all of a sudden, they won't be freaking out or cussing us out because of how we got their information. It is law that everything is reported to us, to the health department, so we can provide adequate follow-up. Speaking of this, yes, this is exactly what I was talking about. When it comes to STI reporting, again, it is law, it is Texas statutory law that HIV labs and other STIs are reportable to the health department. And it's reportable to the health department so we can do all these wonderful things. We can help identify outbreaks. We can break the chain of infection by identifying source and spread of the infection. Partner notification. So when it comes to partner notification, we definitely do reach out to people and let them know they've had an exposure to HIV or STIs, but we do not let them know how we got their information, who gave them information to. We do that in a very private and confidential manner where it protects the client or the index patient to ensure that their privacy is assured. We also provide appropriate referrals. So if you don't know the referrals they need to refer to treatment or anything like that, the health department will follow up with them. We also do ensure that patients are treated adequately for STIs and HIV. And we also ensure that they are referred to social support services to improve their health outcomes. Again, this is law, and healthcare providers must do it, or you're going to get fined. Love you. Please support us. I want to wrap this presentation up because I wanted to kind of reel this in. This is one of my favorite documents when it comes to like HIV work and anything associated with sexual health. It's called the Denver Principles. Now, if you were to read this today, you would have thought this probably came out like 2 or 3 years ago. At least to me, I read it. But this came out in 1981. And rather progressive because it really centered people living with HIV to make informed decisions about their own bodily autonomy and how services are directed and created for them. Okay. Not only did it give them recommendations for people who are living with HIV and the general population that's not impacted by HIV or not deemed to be impacted by HIV, but it gave recommendations for healthcare professionals altogether. The first paragraph says we condemn attempts to label us as victims, a term in which implies defeat, and we are only occasionally patients, quote unquote, a term which implies passivity, helplessness, and dependence upon the care of others. We are people with HIV and AIDS. We are not HIV infected people. We are not infectious vectors of disease. We are people who so happen to be living with HIV. Recommendations for healthcare professionals. This is another reason why I include this too, because this is important. Come out, especially to their patients who have AIDS. Always clearly identify and discuss the theory they favor as to the cause of AIDS, since the bias affects the treatment and advice they give. How I read that is that we need to check ourselves when we're working with people living with HIV. All of our biases, our misconceptions, who we assume to have HIV or who needs testing for HIV needs to be thrown out the window so that we can provide screenings, testing, and prevention for everybody who is either having sex, sparing needles, or exhibiting some type of behavior that could facilitate that transmission for HIV. Get in touch with their feelings, fears, anxieties, hopes, etc. about AIDS and not simply deal with AIDS intellectually. Yes, it is a communal disease. Yes, we do have to think about it in terms of the biological aspects of the work that we do, but we cannot take the humanity out of the work that we do in terms of dealing with people living with HIV. We have to always incorporate humanity, patient-centeredness, trauma-informed decisions that prioritize people living with HIV and AIDS. take a thorough personal inventory and identify and examine their own agendas around AIDS, the agendas around people living with HIV/AIDS, a lot of political things that are hindering and undermining the work that we do in terms of serving people living with AIDS. As healthcare professionals, we should be taking those out of our work so that we can better serve people. Unfortunately, politics does center us around anywhere that we go. As healthcare providers, we're here to serve and protect. So we need to take that out of our biases. Treat people with AIDS as whole people and address psychosocial issues as well as biophysical ones. This is why I would have thought this was made like 2-3 years ago. Because this is I can't say this. This is very progressive for it to be made in 1980s. Okay. Because a lot of people were treating people with HIV as just hands off, don't come near, you're gonna die in the next 3 or 4 years. But this really prioritized looking at people with HIV as people still, regardless if they're not going to be here or not. We need to treat them as people while they are here. Address the questions of sexuality in people with AIDS, specifically sensitivity, and with information about gay male sexuality in general, and the sexuality of people with AIDS in particular. Again, at this point in time, HIV was considered to be a gay-related immunodeficiency, also short for GRID. So they put an emphasis on sexuality because at the time, queer men were being disproportionately impacted. However, this doesn't always apply today, although queer men are definitely disproportionately impacted. But again, the sexuality of people with AIDS in particular, meaning that queer people are not the primary people or the only people impacted by this. We need to take into account sexuality of people as a whole and also realize that sexuality is on a spectrum. Meaning that if I wanted to be straight, never. If I wanted to be straight tomorrow, I could because sexuality is on the spectrum. Okay? So we have to be able to tailor our healthcare needs based on the person and what they're going. I'm only going to focus on the healthcare professional today, but if you want to read the Denver Principles, I definitely recommend reading it. It's really like 1 or 2 pages, but it's so insightful and very motivating to me. And I wanted to include this in the PowerPoint today because, next slide. I want to discuss how we as allied health professionals, I wish the little thing was working today. But how can you as an allied health professional incorporate the Denver Principles into your work to serve communities impacted by HIV? This was supposed to be like a very open-ended dialogue about how we can incorporate Denver Principles and the aspects of Denver Principles in the work that we do. But if you just want to shout out like how you feel like those Denver Principles can be incorporated into your work, whether you know you're working with somebody living with HIV or not, how can that be integrated into the work that you do every single day? Oh, maybe pick one thing. Not playing.
I mean, I think it's just treating people as people.
Mm-hmm.
You literally, as a healthcare provider, you provide care, no matter what that care is.
Mhm.
So somebody is gonna walk into you're gonna give people cancer diagnoses, you're gonna give people other diabetes, right? You're gonna give them all of these different things that they're gonna be impacted for life. They are lifeful, impactful things. So why would you treat this any differently when it's essentially the same idea?
Correct. You treat people as people regardless of their HIV status or their health status in general. You can apply Denver Principles across the continuum of healthcare related issues, but you treat people like people.
And you're also prepared for that conversation.
Mhm.
That's the problem. A lot of times people don't know what questions they're going to be asked.
Right.
So you have to make sure that you have all of your questions.
Right.
Yeah.
Right. Anybody else know how they would integrate the Denver Principles? I have a list, but it's not something right now.
As a provider, I would check my biases and attitudes at the door.
At the door. Absolutely.
Because we all have them,
Me
whether or
too.
not we're conscious of them, but check them at the door because, like you said, this is a person with feelings and thoughts, and they love people, people love them. And so we just have to see them like that instead of our own picture of who people are supposed to be.
Right. Not everybody's monolith. Not everybody's the same. We all come in different shades, shapes, colors, orientations, social economic statuses that really do contribute to where we are in our journey called life. At the end of the day, we still got to treat people with humanity, correct? Does anybody else think of anything that could contribute to integrating Denver principles into the word? Or do we all have like kind of a general consensus?
The other part of this too, because that can be really offensive to someone who, if you don't know. they're,
Absolutely. I don't know if people on the call heard that, but um, addressing people as how they want to be identified. Listen, I'm a 6'3" man with a beard, but if I want to go by she, her pronouns tomorrow, I should be respected as such. Now, no, I do not go by she, her pronouns, but there are people who present a certain way but may identify somewhat differently internally. And if they tell you that they go by a certain name, they go by a certain pronoun, please try your best to respect that. I know you may look at them and may want to call them Steven, even though they go by Stephanie. But if you do make that mistake, apologize for it, especially if it's not done with ill intention. Like gender identity also is on the spectrum. And a lot of people, may not present the way they present externally, internally. So pronouns are a big thing. I'm glad you brought that up. Also, when you're having the sex conversation with your clients, make sure that you realize that trauma happens even before they walk in the door. I always tell people that when it comes to having the sex conversation, a lot of sex is not consensual. A lot of people are forced to have sex. A lot of people are having sex trafficking training yesterday. And that opened up my eyes to so much, but some people are forced to have sex to make ends meet. And at the end of the day, whether it be commercial or sex trafficking, sometimes that can be coercive. And sometimes that can be traumatic. And it stems from trauma situations. People utilize sex to cope.
I think too, you have to respect where people are at with their whole process. I remember this was long before there was any treatment at all, but I had a patient, he was dying of a PCP pneumonia. And he was telling me, well, thank God I don't have that type of pneumonia that people with AIDS have. And I'm thinking, actually, thinking you do, you do. And I don't know if he was saying that for me or he truly was not accepting or didn't truly, I don't know, but I just had to kind of say, well, I mean, at that point, he only had a month or two left. So what benefit would it be to, convince them otherwise?
Also, we can address stigma with our friends and our family about HIV. There's a lot of ignorant stuff being said about HIV amongst my close setting of people. And I don't like to deem them as bad people because they say these things. I like to contribute that to like uneducation and the stigma associated around HIV and sex when we don't have these conversations. So it leads to ignorance. And, a lot of times it's okay to speak up and not be confrontational. You can confront somebody with love, respect, and dignity. But when someone is misspeaking about HIV or people living with HIV or sexual health in general, it's okay to call them out on that. Sometimes it takes a little bit for people to get that superpower, but I'll be quick. Because at the end of the day, if we continue to push this narrative around what HIV was and not where it is now, it's still a public health issue. But there's people amongst us that are living with HIV that are not going to speak about it like I am because of those things that people say. We always have to create safe spaces in a way that put people living with HIV at the forefront, do not stigmatize them, and look at them in a way that is full of dignity, respect, and just a huge high moral compass.
I just want to add, it's also important to, with people who are living with HIV or if you're giving them diagnosis, it's also very important to listen to other barriers they might be facing. Say, for instance, you have a patient that comes in and, you're giving them a new HIV diagnosis and they're saying I'm homeless, you know, or whatever they're experiencing. I think to have those resources readily available for that patient, because they're not going to think about firsthand, like I need to get into care. They're thinking it's like I'm homeless, I don't have any money, I don't have any insurance. And you know, providing those additional resources are so helpful. So listening to the patient, you know, kind of feeling like if I give a patient a new diagnosis, I want to first like, how are you feeling? How are you processing this? If they get quiet, you can tell by the body language, like reading the room and sort of speak and giving them time to process. And then looking at, okay, you can live, you know, you have options. You don't have to worry about you're not insured. You know, we can help you or help you navigate that process and you're not alone.
So if we can spend the last 5 minutes with questions.
Yeah, that's actually perfect because I had a few more slides, but that's fine. What questions do we have? Any questions?
Well, I don't know if you know this, because it's kind of a tough one. Going back to those 3 enzymes, the reverse transcriptase and protease and
Integrase.
that are they the virus itself contributes those, or are they in a host?
They're in, no, they're not in the host. They're actually part of the viral genome of HIV.
Oh,
And that's what the enzymes that help with the actual, basically hijacking of the host cell. That make HIV really actually very hard to cure because it takes its viral DNA, injects it into the host DNA, and uses that DNA within the host cell to replicate. So it makes it very difficult to cure HIV because essentially you have to like kill all the host cells. And that makes it extremely difficult to cure. If you didn't know, there's like 7 people that have been cured 100% of HIV, but it's not a thing that can be practiced on everybody and be expected the same results. It's very far in between. But it's usually due to stem cell research. If you don't have any questions, I have a few more slides that we can go over if there's no questions. There's only like a few more. I think this is very important. So for treatment of people living with HIV, there are social support services that provide treatment and care for individuals who are underinsured or uninsured. It's called Ryan White HIV/AIDS programs. Again, they provide medical treatment and support services for people who do not have the money or the insurance to cover these services. And they aim to improve the quality of life of those impacted by HIV by offering treatment, care, social support services, and various other services to help clients achieve optimal health outcomes and reduce HIV transmissions at a community level. These are just some of the services that Ryan White funded clinics do offer. You can find Ryan White funded clinics in most health departments, but also if you look up Ryan White clinics in your jurisdiction, there's a couple of websites that you can put in a zip code in, and it'll just pop up all the Ryan White funded clinics in the area that again provide all these services at little to no cost. This is a wide array of services they offer from both medical to social support. But one of the biggest things I want to highlight is that according to HRSA, in 2022, 89.6% of people living with HIV who are participating in Ryan White funded services were virally suppressed or reached an unethical viral load. And that is actually pretty amazing. But I think that's an attest to government funding and also all the services that Ryan White funding provide. So again, very and I'm gonna skip this, but
That's fine.
because we're due to time. No, go there. You go.
That one.
And that is pretty much the end of this training capacity building exercise. I just want y'all to know that even if you don't become infectious disease providers by any means of the coin, you will be experiencing people who are living with HIV regardless. Okay. So just having this information in your toolbox will allow you to have these conversations with individuals living with HIV or even recognize testing for individuals who may have HIV and not know it. So I hope that you take this information and expand upon it in your free time. Maybe it does get you in the field of infectious disease and maybe work in public health in a way that we can better serve and provide safety nets. But I hope you take this information and expand upon it so that we can better bring us closer to ending this HIV epidemic. Again, my name is Brian Tyler. I go by he, him pronouns. please scan the QR code for UTA to do the evaluation for this. It will help us improve our programs and also UTA so that we can better provide this training to others similar to it in the future. So again, my name is Brian Tyler. I hope you have a fantastic day. And if y'all have any questions, I don't have my email, but y'all can find me. I'll let the UTA provide y'all with emails and stuff like that.
Yeah, that's good. Well, thanks everybody for joining. I did drop the evaluation link in the chat as well. So if you guys need it later, I know we ran a little over, so I apologize. But thank you guys so much.
Sorry, y'all. Love y'all.
And we are having a bunch of people say thank you for the informative presentation. So thank you so much for joining us today.